Hey everybody, I got asked by Heather to talk to you for a little bit about unusual things you might see in the ICU that you could pick up at the bedside and be the first ones to kind of alert the teams or get us involved. And so today what I'd like to talk about is kind of how we think about unusual trauma presentations for chest injury and sort of the way I think through them, how we can troubleshoot things at the bedside and notice things that may be and should be an alarm for us to pick up on early so that we can intervene and keep bad things from happening. I'll start off with a case. The first case I have is there was a real case, 23-year-old kid. He was not a big guy. He was about 5'5", not a lot of extra body weight, and he was in a motor vehicle collision, unrestrained. He came in on a probably Friday night or Saturday night and went straight to the OR for a splenectomy. He had in his primary survey, he had decreased breath sounds on one side. They put a chest tube in him in the trauma bay. He got to the OR, did okay in the OR, got his spleen out in an hour, for a little bit around an hour. The anesthesiologist felt like he had been doing well enough in the OR that they would extubate him for the PACU. And he got extubated, went to the PACU. And for the first few hours over that night, he did okay. Then probably about 4 a.m., he started having a little bit increased respiratory drive, a little bit use of his accessory muscles. Saturations went from the high 90s to the mid 90s, and then by about 6 a.m. he was starting to have DSATs. Now, the residents at the time thought, oh, it's just a little bit of atelectasis. They got a chest film. He had pretty bad contusion along on the side where that chest tube was placed, and the other side was kind of just normal looking. Didn't have a lot of rib fractures. Didn't have contusions or anything. It looked a little bit collapsed, and so the residents were like, well, he's got pulmonary contusions on one side. He's got what looks like progressive atelectasis on the other side. And so we're going to put him on BiPAP because he was totally mentating, doing fine, just complaining of a little incisional pain. By about 7 or 8 o'clock, when the weekend team is to come in, we get a call from the ICU that the patient needs to be intubated. And so we run over to the ICU. This is in the old ICU before it got torn down. And the anesthesiologist was standing at the top of the bed, and she said, he's crashing. And I looked at the monitor, and he had saturations of about 60%. He had a heart rate that was 130. And so she intubated him, and he really crashed. And I said, I just meeting this person, can somebody tell me what else he had done? And at first I thought, well, maybe he's bleeding in his abdomen. But then I happened to walk around the bed to stand on the side where he had his chest tube, and I looked down at the pleurovac, and the pleurovac was going like that. And I said, you guys, he's got a tracheal injury. He's got something going on in his chest, because look at that, that's crazy. And every time the breath would come with the ventilator, the thing would just get even faster, and I thought the pleurovac was going to explode for a second there. And I told Dr. Kunkel, who some of you may remember, I said, you need to push the tube forward as far as you can. We need to get in his other, luckily it was his left side that was doing all the bubbling. I said, we got to try to cannulate his right stem, his right main stem bronchus. She was shaking like a leaf, and so she pushed the ET tube forward. Thankfully it went into the right side. The bubble subsided a little bit. So we took him upstairs, and she switched him out to a double lumen tube. And we ventilated him on the good side, didn't ventilate him on the bad side, just held it on a little peep so the whole thing wouldn't collapse. And when he started to have too many bubbles, we even backed off of that. I think we had him on 2 of PEEP or something crazy like that on the bad side. And so the point I wanted to make with this case is that when you have, he didn't have a tracheal, you know, I probably overjumped the mark. He had a really bad lung injury, and when he got collapsed on the right side, the other lung got all the air pressure on the BiPAP especially, and that just opened up this injury and created a bronchopleural fistula through the chest tube. And so being able to pay attention to what's happening to your pleurovac is really helpful, especially when you have a person who's starting to go into what this was, an unexpected respiratory compromise in the unit. And so, you know, some of you may have heard me talking to the residents about compliance and lung ventilation. I think, you know, when you have trauma patients, thank you, Heather. When you have trauma patients, the unique thing about trauma patients and, you know, and some of our post-surgical thoracic patients is that their compliance frequently is not the same from side to side. And so when the ventilator or BiPAP or any kind of positive pressure ventilation, so, oh, that's a nice one, positive pressure ventilation happens to push air in, we have no control where that air goes. And by the laws of physics, it always goes to the area of least resistance, which is the area most compliant in the lungs. So with this kid particularly, he had a contusion over here, right? And he had had these ribs that had like shattered and ripped his spleen to bits, which is why he got his spleen taken out that night. So Mr. Spleen's gone. But this lung by nature was already less compliant than this lung because it had all this contusion in it. And so when he was in the OR, they were pretty much ventilating this lung over here. This lung, not so much. This chest tube, because he was probably getting ventilated on both sides a little more evenly and the case was short on the positive pressure ventilation, this chest tube could have been bubbling the whole time. And the bubbles, the fact that he made it through that first operation tells me the bubbles were probably little and then got really big as this injury opened up and the tube just kept decompressing it. Now, you know, this situation set him up for when he was extubated. He was tired, he was having some pain, probably from the chest tube and the injury itself, all the broken ribs. He was, you know, splinting, which we know is a bad thing. And in the recovery room, he started to collapse these alveoli just from not taking deep enough breaths on negative pressure breathing. And so over that few hours after he got out of the OR, this lung goes down. And then what happens is that this positive, when they put him back on BiPAP, now this lung isn't receiving the pressure. This lung isn't venting away from this situation and is not expanding, and so then more pressure is getting pushed on this injury, and that's when it really got big. Okay? So at any point, if somebody had looked at this chest tube and said, whoa, that's a big air leak, you know, anybody in the OR, the recovery room, my residents, you know, had looked at this thing and go, wow, that is a pretty robust leak and is getting bigger, we could have come up with strategies. Now, you know, could we have like rushed into the OR, cracked this guy's chest and taken out that piece of lung? Sure, we could have. But what we did instead at that point, because I had no idea whether this was a bronchus injury, which would have been super bad, right? Mainstem bronchus, I mean, the left mainstem. It could have been a major tertiary bronchus. It could have been a huge chunk of decent lung that I would have had to take out to fix this problem, which is why I said, why don't we try first just trying to open up this lung. He survived on this lung in the OR when it was compliant, and we just lost ground when he got extubated. And so we were super lucky with this kid. We had a double lumen tube in, we didn't ventilate on one side, and we ventilated this lung. So we had a way with the double lumen tubes, particularly, you can then direct which way the air goes. It's not something we want to do a lot of because the tube's so huge, it can cause erosion and problems if it sits there for a really long time in the upper trachea, so it's not something we just routinely want to do. But for this kid particularly, it saved him a thoracotomy and saved him losing a lot of lung. I think the take-home point for anybody at the bedside is that when you have somebody who's got a chest tube in, and they start looking different or having more respiratory problems, go and analyze what's happening with your pleurovac. See if you're actually losing your tidal volumes that would keep the lungs aerated and keep your gas exchange going through an injury that's now going into a pleurovac. So he ended up doing really well. He ended up only needing the double lumen tube, I think, for 5 or 6 days. And as this started to seal off, this injury started to seal off, we were able to increase the pressure gradually on this side. If we go up by a few numbers of PEEP and the bubbles came back, we would back down. It took about 4 or 5 days, which was getting to my comfort level for a double lumen tube. But when it all was said and done, he sealed this thing off. We got the chest tube out long after we changed him to a single lumen. I think he had the single lumen for another handful of days. And he ended up going home probably within 2 weeks of this happening, so without a thoracotomy. And it was just because we were lucky enough to pick this huge bubbling mess over here up after he had decompressed that lung. And I think, Heather, since you're here, based on what I've said, is there any questions I could answer that this story raises for you?
No, so do we have the double lumen tubes in the ICU? Are they easy to find?
The tricky thing about the double lumen tubes is that there's only certain people trained to place them.
Okay.
I think this extreme of a situation when the person's crashing is probably most better done in the OR. Mm-hmm. Because that's where anesthesia is the most comfortable. Anesthesia is the only people I know that are really, really accomplished at placing double lumen tubes. If you suspect it and you don't think the patient's going to make it to the OR, you can always, when you're talking to anesthesia, to come over and intubate, say, please bring double lumen tubes, because they've got them right there. They may or may not be in our difficult airway cart. I don't remember. I know we're trying to keep that light enough to carry around. But if you suspect that you're going to need a double lumen tube, you just tell the anesthesiologist, we might need a double lumen tube. Please bring one with you, and they'll come running with this funky looking thing because it's got all these different, syringes and stuff.
Any other nursing implications for a double lumen tube that they should know about?
Nursing implications.
In particular,
you mean in terms of management of it? Yes. The things you want to watch out for is, as the bedside nurse, you would want to make sure that RT and the residents and even us attendings when we're super sleepy or not thinking, that if we've got a double lumen tube in, it's probably because we're doing single lung ventilation. We want to be careful about what the tidal volumes are, right? Because if you're just ventilating one lung, you're ventilating, depending on which lung, either 60 or 40% of the total tidal volume, right? You're never going to be ventilating the entire tidal volume with a single lumen ventilation, single lung ventilation. So watching the tidal volume, and you have to remember, left side is smaller than the right side because the heart takes up part of it. 55, whatever adds up to 145, or 60-40, depending on, what books you read. And, then you think, okay, ideal body weight, if I was ventilating the whole lungs, it would be, let's say he was of the size, he would have 400 cc tidal volume. And then you go, oh wow, he's doing single lung ventilation. So I wouldn't want to put 400, right? I would want, and since I was ventilating this side, I would say 60% or 0.60 times 400 would give me my goal tidal volume. Okay? So it's just being cognizant that when a person is on a double lumen tube, or even getting single lung ventilation through a single lumen tube that somebody's jammed down the right, or not jammed, but placed in the right main stem bronchus, and then pulling up a balloon, which is not what I would recommend doing for long term, but if for the short term, you definitely have to turn it out, you'll blow a pneumo out on that side. You will cause severe barotrauma if you start doing full lung ventilation volumes to one side, because it's just, you don't have enough architecture, you don't have enough geography there to do it with. So that's probably the biggest thing to keep an eye on, as people come in and play with the vent and things like we sometimes famously do. Watching what the chest tube's doing. I think our nurses are excellent at looking at volume out. I don't think we pay as much attention to the air bubbles, but when it gets like this and it's literally, there's a problem. There's a big problem when you see your pleurovac doing like the rotisserie bubble thing. Yeah, and the kid did great. So another chest thing, another chest physiology thing that, I kind of found fascinating when it all happened, and I learned a lot from, or was reminded of a lot of important basic points about how we breathe. We had a kid, I'm going to say he was a jockey, so he's a little guy. I think he fell from a horse, and he came in with respiratory distress, and we listened, didn't hear any lung sounds anywhere, and so he got a chest film. He wasn't hypotensive yet, but he got a chest film, and he had 2 really impressive pneumos on both sides. And we're like, how did he do that? We saw no broken ribs, 0, nothing broken, nothing contused, nothing. And we're like, what? What's happening? And we needled him because he didn't want us to do anything to him. I think he was from a village in Guatemala where they had this idea that if you came to America, your organs would be taken. And he didn't speak Spanish. He spoke Mom, and that was before we had access to Mom interpreters. So we were having a really hard time getting him to let us do anything to him. But he was terrified. He was convinced we were going to take all his organs. Sweet guy. But he had these pneumos, and we're like, really, we kind of need to drain this air out because you're going to get in trouble. But we took him to the scanner, and we're just like, why does he have these? He doesn't have rib fractures. He doesn't have this. And so on the CT scan, and I'm not going to draw everything because it'll take more than 7 minutes, but when you looked at his trachea, his upper trachea, it had like this funny wiggle stuff on the membranous portion. And for those of you who don't spend a lot of time in the chest like I tend to, the trachea itself, if you look at the anatomy of the trachea, the rings of the trachea go around the anterior aspect like that. So like this. Right? These are the cartilaginous rings, all except for the cricoid, which is a complete circle. But the cartilaginous rings they're like arches. And if you watch us do bronchs, if we put it up on the screen, you can see it. It's like looking down a hallway with arches. And this is the cartilaginous part. This back part is just a membrane. It's just a flat piece of tissue, and it's not that thick of a piece of tissue. It doesn't have a bajillion layers over it because it's against the adventitia of the mediastinum and the anterior thoracic spine. It's just a piece of membrane. And this little fella, somehow, I don't know if he took a deep breath before he hit the ground or what, if he was like holding his breath, but he had blown a big hole in that to the point where he was leaking air this way and he was leaking air that way. Okay? And so what that ended up doing on the chest film is that he had a lung here, a lot of air around both sides, no rib fractures, no other stuff. But he gradually had air leaking into these spaces both ways from the back of his trachea. Now he didn't have a tension phenomenon because he was negative pressure breathing. And the challenge with him, once we finally got a mom interpreter, which I think was in Daytona, Florida, we had him talking over the phone. Once we communicated with him that we didn't want to take his organs and that we just wanted to help him, and it meant us putting these 2 tubes to suck the air out, we had buy-in. He got the tubes, his lungs expanded. Then he was in the ICU because we were all freaked out. We were like, holy cow, is this guy going to need to have some kind of procedure? We're afraid, this is going to get bigger, I was terrified, to be perfectly honest, that this thing would get bigger and that we would be with limited options, basically. And I also knew at that time that he had done this much of a pneumo on negative pressure breathing. And this is what drove it home for me in terms of just a really interesting case, is that the negative pressure breathing basically is what saved this kid. If they had intubated him in the field, they probably would have killed him. And when he was having certain periods of time in the ICU where his respiratory rate would come up a little bit, usually because of pain, because he had like had some spine fractures too, like transverse process and spinous processes. So they had some back pain, and he would like get a little bit in pain, and he'd start to breathe a little bit more. And people were like, "Oh, he's going into respiratory distress. We got to intubate him." I'm like, "Over my dead body. You are not intubating this guy." And it was a long discussion a couple of times at the bedside with the nurses that he would be a lot worse off intubated than he was extubated, and that we needed to do everything we could do to keep him from having progressive collapse from pain, and to move forward with keeping him off the vent. And we had him in the unit probably about 6 or 7 days, with us all going, what's going to happen. Over 6 to 7 days, he stuck, his lungs stuck up. We had him on negative pressure ventilation. He had good approximation to the chest wall from our chest tubes being on suction. He continued negative pressure breathing, which over time helped that injury seal in. And we took the chest tubes out actually when he went up to the floor a few days later, and we had him on water seal for longer than we usually have people on water seal. But he ended up doing okay. But there were a handful of times there where we were like telling everybody coming on shift, "Don't intubate this man. Do not intubate this man. He will get so sick if you intubate him." And they're like, "Yeah, but he's breathing in the 30s. I'm like, "Yeah, let's just treat his pain. Let's just try to get him to, have FiO2 through a nasal cannula, not a high flow, but just a nasal cannula. Don't put him on BiPAP, because, we saw what BiPAP did to the other kid." And he did okay over time. But I think it's really important when you look at the injuries some of these folks have, and you realize how much different the process of negative pressure breathing is in comparison to what we do with the ventilator, which is positive pressure breaths. And there's a couple of instances where negative pressure breathing really is a lot better and a lot more beneficial for the patient in the long run. He never needed an operation. He got his chest tubes out without any need for VATS or anything, and he ended up doing fine. I don't even know if I ever saw him in clinic again, but he left the hospital with all of his organs, which made him happy, and a couple of little scars on his sides where the chest tubes were, but no thoracotomy, no sternotomy, no tracheal repair, nothing like that. He did fantastic, and that's just another piece of the pulmonary physiology that it took a lot of debating with some of the nurses at the bedside when this kid was in the hospital, because there were a couple times he kind of looked good. But we really had to think very hard about what the impact of positive pressure breathing would be on his particular injury. And so that's another case that I think I learned a lot from in the past 17 years I've been here.
Cool. And then in closing, if there were 3 things that you would like the nursing staff to pay particular attention to for trauma patients, what 3 things would you like them to pay attention to?
That has to do with this sort of thing?
Just in general.
In general? After recent events on call, I think, especially when, and I'll take this a step back. I think our system is really complicated here, and I think our system is complicated for a couple of reasons. The first reason is that there's a lot of residents, and at certain times in the year, the residents have more savvy than not. And I don't necessarily think having more savvy is a good thing. Sometimes it's a bad thing. So I think, the first and foremost is that, whether it's July or April, you're dealing with people that don't know anything versus people that think they know stuff. And I think, I would say uniformly across the board, both from the medicine side and the surgery side, if you're super concerned, don't hesitate to call the SICU or the MICU director. Contact them, text them, page them, and just make them aware of stuff if you're concerned. I think we all welcome that. I know we do on the surgical side. So if there's a patient, and hopefully with our rounding more consistently in the last few years, and us trying to be more present, you feel like you have access to us, but we're always on Am I On? You know, my number, I hope, is on boards places. You know, I've had people text my personal cell phone and just say, hey, are you in the hospital? That kind of thing is fine with us, and we just want you to reach out and kind of help you navigate some of these things. And sometimes we'll say, yeah, you know, and we'll all learn something. We'll say, yeah, we really think this person needs volume because of X, or yeah, this chest tube shouldn't look like that, or no, this person shouldn't get intubated. But other times, you know, it'll be like, yeah, the nurse is right, resident, step down. You know, it's kind of that thing, and just getting the attending involved, I think, gets everybody better care, because we've done this a little while. I think the other thing is we have spotty coverage for pharmacy now because of COVID, and the pharmacy we have is, you know, is pretty stretched thin with needs for treatment of other things than ICU things at this point. So I think, you know, if you notice something about the meds that you're concerned about, you know, once again, run it up the chain. Bring it to the ICU team's attention, because sometimes if we're not the primary, it may miss our radar, especially when the residents are new and they're trying to just take in everything. So that, just medication stuff if you're concerned about.
Do you mean medication that you're questioning the appropriateness for that patient?
Or the length of time they're getting
Okay.
it. Yeah, anything with meds. It's like, why are they getting this? You know? And sometimes there'll be a reason, sometimes it's like, yeah, you're right, let's stop it. Yeah. And we're going to be right sometimes, we're going to be wrong sometimes. But I think the more we talk and the more we work together as a team, which is my goal, the better the patients are going to be cared for. And the third thing, so those two, the third thing I think is, you know, if a patient, if you have a gut feeling about a patient and you know, you feel like you're not sure, but it's just something doesn't seem right, to speak up. You know, I think that recently particularly we have a lot of new nursing grads, and welcome, I'm glad you're here, I hope you stay forever. There are nurses that have stayed forever and they're amazing. So, but if something doesn't seem right, just say, hey, can you look at this? And if you ever have my residents say, no, I'm too busy, call me, because that's not okay. Or call me, and if I'm around and I have the bandwidth, or I'll get my partner who's supposed to be covering the unit to show up, you know. But definitely, if you have a gut feeling about something and it's okay, you know, we all learn every day, especially in our unit, because we see crazy stuff. Just feel free to reach out and to say, you know, I'm just trying to piece this together. Something just doesn't feel right about this patient. And you know, my experience with ICU nurses particularly is you're right about 70% of the time. You know, there's something coming down the pike, and you just have this sixth sense is what makes ICU nurses special in my mind. So, you know, honor that and pay attention to it. And I think we'll be able to circumvent some disasters if we're able to do that, and just reach out to get help earlier than later. Don't wait for the person to crash. Just, you know, say, no, he doesn't look quite right. Can you just think about this a little bit more?